You know, this is just a great discussion moving on to what I call advanced prostate cancer therapies. You know, this does date me a little bit because back in the 1940s, when Huggins and Hodges won their Nobel Prize for the discovery that by blocking the testosterone production in men, we can actually reduce the progression and cause prostate cancer to go back into full remission and fade away for a significant period of time. And then we went through a period of time when we would actually remove the testosterone in men through surgery, or we would give them diethylstilbestrol or DES. And we would do all kinds of treatments back in the 50s and 60s and up until the 80s when we then developed the LHRH therapies. I had one individual who said those hormone treatments really can mess a man up. And I think he's right. You know, we don't even know sometimes the full ramifications of hormone therapy. And so I think I'd like to talk a little bit about some of these other agents that have come to market that are really just becoming just so awesome. I would like you to talk a little bit about the oral anti-androgens, how we went from the monocolutamides or the bicolutamides to now what we call the tricolutamides. I think I'll have Jason talk a little bit about that. And then basically have Elizabeth talk about immune therapies and how Provenge was the beginning of it and how it's moved on. And Jason can talk definitely a bit about that as well. So Jason, just some of your thoughts and what do you think about, you know, the role of these oral anti-androgens? They've moved up the food chain, and maybe you can describe a little bit about how that is, what I'm referring to, and how they can really help men who are facing advanced prostate cancer therapy.
Yeah, I think androgen deprivation therapy is the mainstay or the basis for advanced prostate. You know, even though we're going back to the 1940s, you know, it's still being used and it's the, you know, the basis for all advanced prostate cancer therapies, but they're not benign. And when using these therapies, you know, you have to use them selectively and appropriately. They're associated with significant side effects. You know, they'll affect bone health, cardiovascular disease, diabetes, cognitive function, and all those things. They will impact the patient significantly, and it significantly affect quality of life. You know, they'll libido, erectile dysfunction, hot flashes. Everyone who is on these, you know, the hot flashes are very common, and weight gain. So you have to really use these appropriately and selectively. And, you know, we've evolved from just the LHRH therapies now where we have these very advanced oral therapies, you know, that have come out in the last maybe 6 or 7 years that are very powerful agents. They have, you know, every trial where they've been tested have pretty much, for the most part, shown benefit, you know, in the very advanced stages. Now we're moving them closer to the, you know, down the chain into less advanced stages. But they fortunately are very well tolerated, but in a, you know, in appropriately managed, they have overall pretty manageable side effect profiles. But there are side effects, and you know, I think it's key that you know, work with your urologist, your oncologist, and use them appropriately as the studies have shown benefit. You know, I think we've gone from everyone gets ADT now to very clear definitions who will benefit, and applying those only in the patients where clinical trials or studies have shown benefit.
Thank you.
Yeah, and I think, Michael, in terms of immunotherapy, you know, that's a tougher nut to chew. The immunotherapy story for other cancers, lung cancer, renal cancer, and others, have been far more successful. They're already FDA approved. They're out in the mainstream. We see commercials. It's a bit frustrating that they haven't sort of crossed over to prostate cancer, but in general, prostate cancer just has a very tricky biology. Many people, whether you're listening or just you've been on different, you know, websites, know that cancer likes the bone. So having sort of this bone-centric place where it likes to go and create a nest is, in some sense, not conducive to have sort of like this immunoactive kind of story. So a lot of the earlier trials are struggling with knowing what to do. I'm not saying that they're not there. I think it's trying to find out who's the right person to receive immune therapies. There are many trials to ask that question today. And I'm always grateful for those who do enroll, because this is such an important topic. Because if you really think about where immunotherapy started, even before Dr. Jim Allison got his giant Nobel Prize in this field, sipuleucel T was really sort of the first, honestly, in class in prostate cancer to kind of rear its head, to say, hey, here's a whole new way to look at things. And that was right in the infancy many, many years ago. Everybody on this call probably knows somebody who had it and, tolerated it just fine. I think it's trying to know who's the right person. Now we know it's really for those who are pretty asymptomatic, not a lot of cancer, a low PSA, so not terrible pain, no cancer in the liver. So just at the beginning. And I think many practices, whether you get this medicine in urology groups or in oncology groups, recognize that. So they know that if you really have a lot of cancer, that's probably not the right treatment. But I think the important part, Michael, that we've had this discussion is that there's sort of this recognition now that this drug may be active in African-American men more than in Caucasian men. And that data is just holding and holding and holding. We're not really sure why, but to see that is really refreshing, because in a cancer that really has more morbidity and mortality for the African-American man, it's really refreshing news. And I don't know how you both feel about that, but it does give us hope to say there's a lot more work to be done, but it's really exciting data.
Yeah, the data is pretty remarkable, and it's rare that you see race as a predictor of response to therapy. And Elizabeth, to your point, the Prostate data, which was 2,000 patients in a phase 4 study, and when they subdivided the African American to non-African Americans, there was significant survival advantage to African Americans. So, serving Detroit area in Michigan, we have a large African-American population. I think it's critical as urologists and oncologists that we offer these therapies, especially to the African-American men who unfortunately typically present with more aggressive disease, more advanced disease. And for some reason, hopefully we'll figure it out soon, they respond very well to immunotherapy. But like Elizabeth said, immunotherapy has a very, defined role and when it should be used in that early stage asymptomatic patients. And the beauty of most immunotherapeutics is they're very well tolerated. The side effect profile is very easily tolerated, and they can literally add years to patients' lives.